You know that feeling when you like stub your toe really hard and get that shooting pain?
Oh, yeah.
Imagine something like that, a nerve misfiring, but showing up unexpectedly after a medical procedure. Maybe some weird tingling or even pain after something like a knee scope you thought was all done.
Right. It definitely makes you think about what's going on under the surface.
Exactly. And that's the kind of deep dive we're doing today. We're jumping right into the world of regional anesthesia.
Yeah, we've pulled together a lot of really solid information for this. We're drawing from core clinical anesthesia textbooks, the standard stuff, plus related medical literature.
So reliable sources.
Definitely. And our mission today basically is to really unpack regional anesthesia, how it works, the different types, potential side effects, and, all the factors that play into how well it works and how safe it is.
Think of it as getting the inside scoop on how doctors can selectively turn off parts of the nervous system. Whether you're just curious about how medicine works, or maybe you're prepping for a procedure yourself and want to be really informed.
Or just interested in the body, yeah.
We're here to break down the details, make it engaging, make it clear. So, where should we kick things off? How about something called transient neurologic symptoms, TNS?
TNS, yes. Good place to start. It used to be called transient radicular irritation.
Okay.
And it's something that can happen after spinal anesthesia. What's really striking right away is the incidence rate. It's reported anywhere from like 4% up to 40%.
That's a huge range, 4 to 40%.
It is, and it seems particularly more common in ambulatory patients, people going home the same day who get spinal anesthesia with lidocaine, especially for surgeries in the lithotomy position.
Like for GYN or urology stuff.
Exactly, or for knee arthroscopy. So yeah, that 4% to 40%, it's a pretty wide swing.
It really is, almost a coin flip at the high end.
Yeah.
So if someone gets TNS, what does it actually feel like? What are the symptoms?
The main things are pain, or sort of abnormal sensations, usually in the lower back, the buttocks, or sometimes radiating down the legs.
Okay.
Now, the key thing here, and this is really important, is the strong link with lidocaine. While TNS has technically been reported with pretty much all local anesthetics used for spinal blocks, the data really points to a significantly higher incidence when lidocaine is used compared to others.
So lidocaine's the main player, but not the only one.
Exactly. It's been seen with others, but lidocaine definitely stands out.
That's really good to know.
Yep.
You mentioned specific procedures, ambulatory patients, lidocaine. What else might influence whether someone gets TNS? Are there other factors involved?
Well, what's kind of interesting is what doesn't seem to be strongly related. Things you might think would matter, like the baricity of the anesthetic, whether it's heavier or lighter than the spinal fluid, or the concentration of the lidocaine, even across a big range, like 0.5% up to 5%. Or adding epinephrine to make it last longer. Or having dextrose in the mix, even if the patient's blood pressure drops during the procedure. None of those seem to be consistently linked to a higher risk of TNS.
Really? That's surprising.
It is. The exact why behind TNS is still being figured out. It's still a bit of a puzzle, honestly.
Fascinating. Shows how much we're still learning. Okay, let's pivot a bit. Let's talk about ultrasound. That technology seems to have really changed things in regional anesthesia, hasn't it?
Oh, absolutely. Ultrasound guidance has been, revolutionary for nerve blocks. It gives us this amazing ability to actually see the nerves and the structures around them in real time.
Right, so you're not just going by landmarks anymore.
Exactly. We can see the needle, see the nerve, see blood vessels. It makes placing the needle much more accurate, and that improves effectiveness and, importantly, safety.
So, when you're using ultrasound for a block, what are you adjusting to get the best possible image? It's not just point and shoot, I assume.
No, definitely not. Getting a good, clear image is key. And that means optimizing a few main things on the machine. The frequency, the depth setting, and the gain.
Okay, let's break those down. Frequency first. What does changing the frequency do?
Right. So frequency affects two main things: resolution, how much detail you see, and penetration, how deep the ultrasound waves can travel effectively.
Okay.
Higher frequency waves, say 7 to 15 megahertz, give you fantastic resolution near the surface. You see tiny nerves, vessel walls, tissue layers really clearly. But those high-frequency waves lose energy faster as they go deeper. It's called signal attenuation, so they don't penetrate very far.
Gotcha, like a flashlight beam fading.
Exactly. Now, lower frequency waves, maybe 2 to 5 megahertz, they penetrate much deeper, so you can see structures that are further down.
But the picture isn't as sharp.
Right. The resolution is lower. You lose some of that fine detail, so it's always a trade-off. You pick the frequency based on how deep your target nerve is.
Makes sense.
Yeah.
And what about adjusting the depth and the gain?
Depth is pretty straightforward. You adjust the depth setting so your target structure, the nerve, the surrounding area, is basically centered on the screen, top to bottom. You want it nicely filling the view.
Okay.
Gain. Gain is like the brightness control. It amplifies the returning ultrasound signals.
So if the image is too dark,
You turn up the gain, makes everything brighter. But you don't want to crank it up too high,
why not?
because too much gain adds noise or artifact to the image. It can make things look fuzzy or create false echoes, making it harder to see the real structures clearly. So you adjust it for optimal brightness without too much noise.
So it really is a skill, combining the tech knowledge with the anatomy. Okay, let's shift to another potential issue.
Post-dural puncture headache, PDPH. I've heard that can be pretty rough.
It really can be quite debilitating for some people, yeah. PDPH is basically a headache that can develop after you've had a puncture of the dura mater.
The membrane around the spinal cord.
Exactly. That tough outer layer holding the cerebrospinal fluid, the CSF, most commonly happens after a spinal tap or spinal anesthesia. And it's caused by...
It's thought to be caused primarily by CSF leaking out through that hole in the dura. Losing that fluid lowers the pressure around the brain, and that drop in pressure seems to be what triggers the headache.
A pressure headache from a leak. Got it. So why do some people get it and others don't? Are there risk factors?
Yeah, there are definitely factors that influence the risk. Age is one. Younger adults tend to get it more often than older folks or kids.
Interesting.
Sex seems to play a role too. Women have a slightly higher incidence than men. And pregnancy significantly increases the risk compared to non-pregnant women.
Why pregnancy?
It's likely a mix of hormonal changes and maybe increased abdominal pressure affecting CSF dynamics.
Okay. What about the procedure itself? Does the needle make a difference?
Oh, absolutely. Since it's about CSF leakage, the hole matters. Bigger needles make bigger holes, leading to potentially more leakage and a higher risk.
Makes sense.
And the type of needle tip is really important too. Traditional cutting needles, like the Quink needle.
They have a sharp edge.
Right, a sharp bevel designed to cut through tissue. Those are associated with a higher incidence of PDPH compared to non-cutting needles.
Non-cutting. Like pencil point needles.
Exactly, like the Whittaker or Sprott needles. They have a more rounded tip, sometimes with a side opening. The idea is they separate or spread the dural fibers rather than cutting them cleanly.
Trying to make a smaller, self-sealing hole.
That's the goal. And even the orientation matters. If the needle bevel is aligned with the direction of the dural fibers, splitting them longitudinally, you tend to get less headache than if you cut across them transversely.
Wow, lots of subtle factors. What about getting up and walking around afterwards? Does lying flat help prevent it?
That's a common belief, but the evidence doesn't really support it. Studies haven't shown that the timing of ambulation actually affects the incidence of PDPH.
So forcing people to lie flat for hours might not be necessary.
Probably not for preventing the headache itself. Of course, you still need to make sure the block has worn off enough so the patient can walk safely without falling. That's crucial.
Right, safety first. Okay, let's switch gears again. Talk about visceral pain, that deep, kind of vague pain from our internal organs. How is that different from, say, skin pain?
It's quite different, yeah. Visceral pain from your chest or abdominal organs travels along different pathways than somatic pain from skin or muscles.
How so?
Almost all of that visceral pain information travels via the sympathetic nervous system, and it uses mostly unmyelinated type C nerve fibers.
I see, those are the slower ones, right?
Much slower conducting than the myelinated A delta fibers that often carry sharp, localized pain signals from the skin.
And that difference in fibers explains why visceral pain feels different.
Exactly. It contributes to that characteristic quality, dull, aching, maybe burning, and it's often really poorly localized. Hard to point to exactly where it hurts.
Yeah, that vague, deep feeling.
Right. And that's partly because the pain receptors, the nociceptors in the organs, are spread out more diffusely. Also, what triggers visceral pain is often different. Stretching or distension of an organ, like your gut or bladder.
That hurts more than a cut.
Often, yes. Cutting the gut might cause less pain than significant distension, whereas with skin, a sharp cut is very painful and localized.
Interesting distinction. What about the vagus nerve? Doesn't that connect to a lot of organs?
It does. The vagus nerve has tons of afferent fibers carrying sensory info from the viscera. But crucially, those fibers are mostly involved in regulating organ function, not transmitting pain signals. Visceral pain relies mainly on those sympathetic pathways.
Got it. Okay, let's talk duration. When someone gets a regional block, how long does the numbness last? It must vary a lot.
Oh, hugely. Duration depends heavily on, well, two main things: which local anesthetic drug is used and where the block is performed.
So different drugs last different amounts of time.
Absolutely. They have different chemical properties, get absorbed and broken down by the body at different rates. Let's take bupivacaine, a common one. If you use bupivacaine with epinephrine,
The epinephrine makes it last longer.
right, it constricts blood vessels, slows down how fast the drug gets washed away. So bupivacaine with epi for an epidural block might last anywhere from, say, 180 to 350 minutes.
So 3 to almost 6 hours.
Roughly, yeah. But if you use that same mix for just infiltration under the skin, it might be more like 180 to 240 minutes, 3 to 4 hours.
Shorter for infiltration.
Generally. But then for major nerve blocks, like blocking the nerves in the armpit for arm surgery.
An axillary block.
Yes. With bupivacaine and epi, that could last much longer, maybe 360 to 720 minutes.
6 to 12 hours. Wow.
Yeah, often because the drug is put in a more confined space near the nerve, so it sticks around longer.
Okay, so location matters a lot. How does a spinal block with bupivacaine compare?
Spinal bupivacaine, if you use it without epinephrine, usually has a shorter duration than many of those Percarol blocks, typically in the range of maybe 90 to 200 minutes.
An hour and a half to just over 3 hours.
Right. But just like with other blocks, adding a little bit of epinephrine, maybe 0.2 or 0.3 milligrams to that spinal bupivacaine.
Extends it.
Yep. It can prolong the block duration by roughly 50%. So it gives us a way to adjust how long the anesthesia lasts based on the surgery.
That's really useful control. Okay, let's dive into some specific blocks. What about the psoas compartment block? Sounds deep.
It is. The psoas compartment block, or posterior lumbar plexus block, targets the lumbar plexus nerves deep in the lower back within the psoas muscle.
And what's it used for?
It's great for surgeries on the proximal thigh and the hip, provides really good pain relief there. And if you combine it with a sciatic nerve block,
Which gets the back of the leg.
right, then you can potentially get complete anesthesia for the whole leg, useful for big lower extremity surgeries.
Since it's so deep in that psoas muscle, how do you actually find the right spot?
Good question. Because it's deep, we often use a nerve stimulator needle. We're usually aiming near the femoral nerve, which is the big nerve coming from the lumbar plexus that controls the quadriceps muscle at the front of the thigh.
So you look for a muscle twitch.
Exactly. We insert the needle, often with ultrasound now too, for safety, and apply a small electrical current, like 1 to 1.5 milliamps. If the needle's near the femoral nerve, you'll see the quad muscle contract. That tells you you're in the right neighborhood.
And if you get the wrong muscle twitch,
Like if you stimulate the hamstrings at the back of the thigh, that means your needle is too far down, too caudal. You need to redirect more towards the head, more cephalid to hit the lumbar plexus.
clever.
And another thing with psoas blocks, we often place continuous catheters there. Thread a little tube in after the block so we can keep giving anesthetic for pain relief after surgery.
For prolonged analgesia. Nice. Okay, let's move down to the foot. Seems small, but I bet the nerve supply is complicated.
It is intricate, but there's a helpful rule of thumb. Pretty much all the nerves supplying the foot, both sensory and motor, with one main exception, come from the sciatic nerve.
The big one down the back of the leg.
That's the one. As it goes down past the knee, the sciatic splits into the tibial nerve and the common peroneal nerve.
And those cover the foot.
Mostly, yes. The tibial nerve generally handles the sole of the foot, the plantar side, and the back of the lower leg. The peroneal nerve branches cover the top of the foot, the dorsum, and the front and side of the lower leg. So if you want to block the foot for surgery below the knee, you can target those two nerves, tibial and peroneal, behind the knee in the popliteal fossa.
Okay, but you mentioned an exception.
Yes, the saphenous nerve. That's the key exception. It does not come from the sciatic nerve.
Where does it come from?
It's actually a purely sensory branch of the femoral nerve, way up in the thigh.
The same nerve we just talked about with the psoas block.
The very same. The saphenous nerve runs down the medial side, the inside of the lower leg. It provides sensation from around the knee down to the inner ankle bone, the medial malleolus.
So if surgery involves that inner part of the ankle or lower leg.
Then blocking just the sciatic branches isn't enough. You need to do a separate block for the saphenous nerve to get complete coverage below the knee. It really highlights needing to know the specific nerve territories.
Definitely. Okay, shifting to potential problems. What about complications with a celiac plexus block? That one targets abdominal pain, right?
Yes, the celiac plexus block aims to block sympathetic nerves carrying pain signals from abdominal organs, often used for pain from things like pancreatic cancer. because it hits the sympathetic system.
Blood pressure issues.
Exactly. Hypotension, a drop in blood pressure, is a primary concern. Blocking those sympathetic nerves causes blood vessels to dilate, which can reduce blood return to the heart preload drops.
How do you manage that?
We usually give patients IV fluids beforehand, like lactated ringers, to sort of fill the tank and help maintain blood pressure.
Makes sense. Any other common side effects?
Well, since you're blocking sympathetic input to the gut, the parasympathetic system can become unopposed. That might lead to increased gut activity, maybe some transient diarrhea.
Okay.
Back pain near the injection site is also pretty common. And then there are rarer but more serious potential complications, such as things like paraplegia, which could happen from artery spasms supplying the spinal cord, direct injury, or the drug tracking back towards the cord, seizures if anesthetic gets into a blood vessel, or a retroperitoneal hematoma bleeding behind the abdominal cavity if a vessel gets nicked.
So careful technique is paramount.
Absolutely crucial. Understanding the anatomy and being meticulous.
Moving up to the head and neck. What's an occipital nerve block used for?
Occipital nerve blocks target the greater and lesser occipital nerves at the back of the head. These nerves come off the C2 and C3 spinal roots in the neck, part of the cervical plexus.
And you block them for?
Mostly used diagnostically, actually, to help figure out the cause of head and neck pain, like occipital neuralgia or certain types of headaches.
So you numb the nerves to see if the pain goes away?
Pretty much. If the block provides significant temporary relief, it strongly suggests those nerves are involved in the patient's pain pathway. It helps guide further treatment.
So diagnostic more than long-term treatment usually?
Often, yes, though it can provide some temporary relief too.
Okay, let's talk about blocks for the chest area. Thoracic paravertebral blocks. What are they?
Thoracic paravertebral blocks involve injecting local anesthetic into the space right next to the thoracic vertebrae, the paravertebral space.
And their use?
They're really useful for surgery and post-op pain relief for procedures on the breast, the armpit, axilla, or the chest wall. Think mastectomy, lymph node dissection, even rib fractures.
Sounds effective. What's the main risk?
The biggest specific risk is pneumothorax, a collapsed lung. It can happen if the needle accidentally punctures the pleura, the lining around the lung.
Yikes. Okay, that's serious. Other potential issues?
Well, that paravertebral space connects medially with the epidural space through the holes where the nerves exit the spine.
The intervertebral foramina.
Right. So if you inject a large volume of anesthetic, it could potentially spread into the epidural space, giving you a more widespread block than intended.
So volume matters. How much is typically used?
For a one-sided block, maybe 5 millilifts at 3 different levels. For a two-sided bilateral block, maybe smaller volumes, like 3 millilifts, at up to 6 levels.
Okay.
Another risk is accidentally injecting into the spinal fluid itself an intrathelical injection. If the needle goes too far medially, towards the midline.
Total spinal.
Could be, yeah.
Okay.
Especially if a decent volume goes in, the dura actually extends out a bit along the nerve roots, forming dural sleeves. Hitting that could lead to a high spinal block.
Affecting breathing and blood pressure.
Definitely. And you can also get sympathetic blockade on that side, since the sympathetic chain runs nearby, so hypotension is more likely than hypertension.
Again, precision and anatomical knowledge are key. Now, what about the scenario where an epidural dose accidentally goes into the subarachnoid space? That sounds like it could cause major problems.
It can, unfortunately. And an unintentional subarachnoid injection of an epidural dose, which is a much larger volume than a standard spinal dose, leads to a very rapid, very extensive spinal block.
What are the immediate effects?
You'll see a profound drop in blood pressure, usually. That's from blocking all those sympathetic nerves from T1 down to L2. It's especially bad if the patient is already low on volume.
And heart rate.
Often bradycardia, a slow heart rate because you block the cardiac accelerator fibers coming from T1 to T4.
What about breathing? That seems really vulnerable.
Respiratory arrest is a huge concern. It can happen because the severe drop in blood pressure reduces blood flow to the breathing centers in the brainstem.
Okay.
And also, the anesthetic can travel high enough up the spinal cord to paralyze the phrenic nerve, C3, 4, 5, keeps the diaphragm alive, which controls the diaphragm, your main breathing muscle.
Wow. Any other signs?
You might see the pupils dilate mydriasis, though they usually return to normal as the block wears off. And very rarely it's been linked to cauda equina syndrome, nerve damage at the bottom of the spinal cord, especially with certain older anesthetic formulations.
What's the immediate management for that kind of accidental high spinal?
It's all about the ABCs: airway, breathing, circulation, immediate, aggressive supportive care, secure the airway, ventilate with 100% oxygen, support blood pressure with fluids and vasopressors. That's paramount.
Anything else?
If there was an epidural catheter in place, you might try to aspirate CSF back through it. You won't get much drug out, but it could theoretically reduce the pressure a tiny bit. But mainly, it's support and monitoring until it wears off.
A critical situation demanding quick action. Okay, let's shift again. What if a patient still feels pain, even though they seem to have a perfectly good spinal block? Like their legs are numb, but they report pain.
That's a really interesting and important clinical question. If you have what looks like a solid spinal block, good sensory and motor blockade in the legs, sympathetic block, but the patient still reports significant pain in that area.
Yeah. What does this suggest?
It often points towards a central pain mechanism rather than the pain signal coming from the periphery that the block should be covering.
Central meaning? The brain or spinal cord itself?
Exactly.
Yeah.
It could be several things. Maybe encephalization, where the pain perception is being generated or amplified higher up in the brain. Or psychogenic factors could be playing a major role.
Oh.
Or you have to consider if the actual source of the pain, the lesion, is located above the level of the spinal block, maybe higher in the spinal cord or even in the brain. The spinal anesthetic wouldn't touch that.
So the block is working, but the pain source is somewhere else the block isn't reaching.
Precisely. So persistent pain, despite a good block, really prompts a deeper look into these central mechanisms or lesions higher up in the nervous system.
Really highlights the complexity of pain perception. Okay, let's consider another acute problem. A seizure caused by local anesthetic toxicity. What happens physiologically during that?
A seizure from local anesthetic getting into the bloodstream in high amounts causes major physiological shifts. The intense muscle activity and often impaired breathing, hypoventilation,
Leads to low oxygen.
right, arterial hypoxemia, and acidosis, the blood gets too acidic. It's both metabolic from the muscles producing lactic acid and respiratory because you're not blowing off CO2 properly.
So first step is oxygen.
Absolutely. 100% oxygen immediately is critical.
You mentioned the CO2 buildup, the respiratory acidosis. How does that play into it?
Well, high CO2 levels, hypercarbia, do a couple of things, and they're kind of counterproductive here. First, high CO2 dilates blood vessels in the brain.
Which brings more anesthetic to the brain.
Unfortunately, yes. Increases delivery of the drug that's causing the problem. Second, CO2 is acidic. It gets into nerve cells and lowers the intracellular pH, makes the inside of the cell more acidic.
And that matters because...
Because local anesthetics are weak bases. In a more acidic environment inside the cell, more of the drug becomes ionized, charged. And that ionized form gets trapped inside the cell because it can't easily cross back out through the membrane.
So it accumulates inside the nerve cell.
Right, potentially worsening the seizure activity. It's called ion trapping.
Wow, that's complex. What about hyperventilation? Breathing faster for the patient? Does that help?
Hyperventilation has mixed effects. On the plus side, blowing off CO2 causes cerebral vasoconstriction, which could reduce anesthetic delivery to the brain.
Okay, that sounds good.
And it causes respiratory alkalosis, making the blood less acidic and can lower potassium levels. Both of those things can make nerve cells less excitable, raising the seizure threshold.
But there's a downside.
Yes. Making the blood more alkaline shifts the anesthetic outside the cell towards its non-ionized form, and that non-ionized form crosses cell membranes more easily. So while you might decrease delivery to the brain, you might actually increase uptake into the brain cells for the drug that's already there.
Complicated trade-offs.
Very. Which is why the definitive treatment for these seizures is giving anticonvulsant drugs, quickly benzodiazepines like midazolam or diazepam, or sometimes propofol to directly suppress the brain activity.
Got it. Okay. Let's look at the anesthetics themselves. You mentioned esters and amides before. Can you recap the difference, especially how they're broken down and the allergy issue?
Sure. The two main chemical classes are amino esters and aminoamides. A quick trick is the name. Amides usually have two I's, lidocaine, bupivacaine, ropivacaine, mepivacaine, prilocaine, edivdocaine.
And they're broken down where?
Amides are metabolized mainly in the liver by enzymes like the cytochrome P450 system.
Okay. And the esters?
Esters typically have only one iprocaine, chloroprocaine, tetracaine, cocaine, benzocaine. They get broken down differently.
Oh.
Primarily in the blood plasma by an enzyme called pseudocholinesterase. This breakdown in the blood usually means they have a shorter duration of action than many amides.
And the allergy connection?
True allergic reactions, the IgE-mediated kind, are actually pretty rare overall, but when they happen, they're much more commonly associated with the ester group.
Why is that?
Because a major breakdown product of esters is para-aminobenzoic acid, PABA, and PABA is known to trigger allergic reactions in some people.
Ah.
And amides don't produce PABA.
Correct. They're metabolized differently in the liver, no PABA involved. So true allergies to amides are exceedingly rare. Often what someone thinks is an allergy might be a side effect of the drug, maybe from getting too much systemically, or a reaction to a preservative like methylparaben in a multi-dose vial.
So if someone reports an allergy, it needs careful investigation.
Definitely. Allergy testing might be needed, but generally if you're allergic to an ester, you can safely receive an amide and vice versa. Very little cross-reactivity between the classes.
Good to clarify. Let's zoom right down to the nerve level. How does a nerve axon actually work, and how do these drugs stop it?
Okay, basic nerve structure. The axon is the long projection from the nerve cell body that carries the electrical signal. In peripheral nerves, every axon is wrapped by Schwann cells.
Sometimes forming myelin.
Right. If the Schwann cell wraps around many times, you get a myelin sheath. This myelin acts like insulation.
And that speeds up the signal dramatically. In non-myelinated nerves, the signal, the action potential, travels like a continuous wave down the axon, relatively slow. But in myelinated nerves, the myelin sheath has gaps, the nodes of Ranvier. The signal literally jumps from node to node saltatory conduction. Much, much faster.
And does myelin affect how anesthetics work?
Interestingly, yes. Myelination makes nerves conduct faster, but it also seems to make them more susceptible to being blocked by local anesthetics, likely because the drug action is concentrated at those nodes of Ranvier.
So how do they block the signal? What's the action potential?
The action potential is basically a rapid change in the electrical charge across the nerve membrane. When the nerve gets stimulated past a certain threshold, special channels open up voltage-gated sodium channels.
Letting sodium rush in.
Exactly. Positively charged sodium ions flood into the cell, causing that electrical change, the depolarization that travels down the nerve. Local anesthetics work by physically blocking these sodium channels.
We plug them up.
Essentially, yes. They bind to a site on or inside the channel and prevent it from opening properly, or lock it in an inactive state. No sodium influx means no action potential can be generated or propagated. Signal stops, nerve transmission blocked.
Blocks the message. Cool.
Yeah.
Okay, back to specific blocks. Interscaling block sounds like it's in the neck.
It is. It targets the brachial plexus nerve roots high up in the neck in the groove between the scalene muscles. The needle usually goes in around the level of the C6 vertebra.
How do you find C6?
You can usually feel the cricoid cartilage, that prominent ring below the Adam's apple. C6 is typically just lateral to that.
And what does injecting there cover?
It primarily affects the C5, C6, and sometimes C7 nerve roots. These are the main nerves supplying the shoulder and upper arm. So it's great for shoulder surgery, arthroscopy, rotator cuff repairs, that kind of thing. Provides a lot of the skin sensation, but not always all of it.
Not all of it. What might be missed?
Especially with lower volumes of anesthetic, you might spare the C3 and C4 roots, which supply sensation to the very front of the shoulder. And you also often spare the lower roots, C8 and T1, which are more important for the hand and forearm. So if you were doing hand surgery, an interscalene block alone usually isn't enough. You'd need to supplement, maybe block the ulnar nerve lower down.
And for shoulder surgery, do you sometimes need more than just the interscaling?
Sometimes, yes. For really complete shoulder anesthesia, especially for arthroscopy, you might need to add a superficial cervical plexus block to cover those C3, C4 areas on the front top of the shoulder that the interscale might miss.
So it's about layering the blocks sometimes to get full coverage.
Got it.
Let's talk infection prevention. Obviously critical. What are the key things in regional anesthesia?
Absolutely critical. And the cornerstone really is meticulous hand hygiene. Washing with soap and water if hands are dirty, but mostly using alcohol-based hand rubs.
Alcohol rubs are better.
Generally more effective at killing bugs than just soap and water, though soap and water are needed to remove physical dirt. Using sterile gloves is, of course, mandatory for the procedure itself.
What about things like long fingernails or wearing gowns?
Well, research suggests most bacteria on hands are near the fingertip, the proximal 1 millimeter of the nail, so short, clean nails are good, but it's the hand hygiene and sterile gloves that are most vital. As for gowns, while standard in ICUs for some things, the evidence that universal gown use significantly reduces infection risk during regional anesthesia, beyond just gloves and hand hygiene, isn't as strong. Aseptic technique and hand hygiene are really the pillars.
Focus on the fundamentals.
Uh,
Okay, what about patients on blood thinners? Huge issue for spinal and epidural blocks, right? Risk of bleeding around the spinal cord.
Massive issue. An epidural or spinal hematoma, bleeding compressing the spinal cord, is a devastating complication. So we have very specific guidelines, especially for drugs like low molecular weight heparin, LMWH, things like enoxaparin, dalteparin.
What are the rules for LMWH?
It depends on the dose. If it's a lower prophylactic dose to prevent clots, you generally need to wait at least 10 to 12 hours after the last dose before doing a neuraxial block.
And if it's a higher treatment dose for an existing clot?
Then you need to wait longer, usually at least 24 hours after the last dose. And there are also strict rules about when you can restart the LMWH after the block or after catheter removal.
Okay. What about antiplatelet drugs? Aspirin, Plavix.
Also important, things like NSAIDs, ibuprofen, naproxen, ticlopidine, clopidogrel, Plavix, they all affect platelet function.
Are NSAIDs alone a major problem?
Generally, NSAIDs by themselves aren't considered a major contraindication for neuraxial blocks in most patients, but the stronger antiplatelet drugs require waiting periods.
Like Plavix.
For clopidogrel, Plavix, the recommendation is typically to wait 7 days after stopping it before doing a spinal or epidural. For ticlopidine, it's even longer, 14 days.
Wow, 2 weeks.
Yeah. It's crucial to get a detailed medication history and follow the established guidelines, like those from SRA, the American Society of Regional Anesthesia. Assess the individual patient's risk carefully.
Absolutely essential. Okay, let's discuss adding sodium bicarbonate to local anesthetics. Why is that done?
The main reason is to speed up the onset of the block, make it work faster.
How does that work?
Local anesthetics often come prepared, especially those with epinephrine, at a slightly acidic pH for stability. Adding bicarbonate, which is alkaline, raises the pH of the solution.
And raising the pH?
Shifts the equilibrium of the local anesthetic molecule towards its non-ionized, uncharged form. That non-ionized form is more lipid-soluble. It crosses the nerve membrane faster to get inside the nerve cell where it works, so faster onset.
Clever. Any downsides?
You have to be careful not to add too much bicarbonate or raise the pH too high, generally above 6 or maybe up to 8 depending on the drug, because the anesthetic could precipitate, basically fall out of solution.
Become cloudy or flaky.
Exactly. Then it's no good. Also, some studies suggest adding bicarb might slightly decrease the duration of the block, maybe especially if there's no epinephrine in the mix. But a definite benefit is that adding bicarbonate usually makes the injection less painful, especially when infiltrating the skin.
Less stinging.
Right. Though injecting slowly also helps reduce injection pain, regardless of bicarbonate.
Good tips. Can you walk us through the layers again just quickly that a spinal needle goes through?
Yeah.
From skin to spinal fluid.
Sure. So, starting from the back, skin, then subcutaneous tissue, fat, then ligaments, the supraspinous ligament running along the tips of the spinous processes, then the interspinous ligament between the processes.
Okay.
Next is the ligamentum flavum, the yellow ligament, which is quite thick and forms the back wall of the spinal canal. Passing through that, you enter the epidural space.
Which has fat and blood vessels.
Right. And then finally, you puncture the duramater, that tough outer membrane, to enter the subarachnoid space where the CSF is.
Got it. Skin, fat, ligaments, flavum, epidural space, dura, subarachnoid space.
You got it.
And if you went too far through the subarachnoid space,
You'd hit the anterior dura, then maybe the posterior longitudinal ligament, which runs on the back of the vertebral bodies, then the periosteum, bone covering, and finally the bone of the vertebral body itself.
okay, clear picture now. Let's compare bupivacaine and lidocaine again, but specifically in the epidural space. How do they stack up for potency and duration there?
Right. In the epidural space, bupivacaine and its cousin levobupivacaine is significantly more potent than lidocaine. About 4 times more potent, roughly.
Meaning you need less drug for the same effect.
Exactly. For example, a 0.5% bupivacaine solution gives similar analgesia, pain relief, as a 2% lidocaine solution.
And duration.
Bupivacaine is much longer acting. An epidural with bupivacaine will last considerably longer than one with lidocaine.
Any difference in the type of block, like sensory versus motor?
Yes, that's a key difference. Bupivacaine tends to produce less motor block relative to its sensory block compared to lidocaine. We call that greater differential blockade.
So more numbness, less weakness.
Kind of, yeah.
Yeah.
Which is often desirable, like for labor epidurals where you want pain relief but hope the patient can still move their legs somewhat and push effectively.
Makes sense why it's used so much in OB. Okay, what about adding other drugs besides epinephrine into a spinal anesthetic? Adjuvants, you call them.
Yes, intrathecal adjuvants. They're added to the local anesthetic in the spinal fluid to enhance the block or provide better post-op pain relief.
Like what?
Well, alpha-adrenergic agonists like phenylephrine, epinephrine, or clonidine have some analgesic effect themselves, probably via alpha-2 receptors in the spinal cord. They also cause vasoconstriction, which can prolong the local anesthetic effect, but maybe increase hypertension risk too. Clonidine actually works pretty well as a sole spinal analgesic sometimes.
Interesting. Anything else?
Neostigmine has been tried, but isn't used much due to side effects. The most common and effective adjuvants, though, are opioids.
Like fentanyl or morphine.
Exactly. Short-acting ones like fentanyl or sufentanil are great for boosting the anesthesia during shorter surgeries and giving some immediate post-op relief. Longer-acting ones like hydromorphone or morphine are often added for longer surgeries or when you really want extended pain relief afterwards. They work directly on opioid receptors in the spinal cord.
So you can really tailor the spinal cocktail. Okay. Last couple of topics. Can you give us a quick rundown of the different ways local anesthetics are given, routes of administration?
Sure. There are many ways. Topical, applying to skin or mucous membranes. Things like lidocaine, tetracaine, cocaine, benzocaine, EMLA cream work well topically.
Okay.
Then there's intravenous regional anesthesia beer blocks, injecting into a vein in an arm or leg with a tourniquet on.
Which drugs for that?
Lidocaine and prilocaine are common and safe. You generally avoid esters because they break down too fast, and one, chloroprocaine, caused vein irritation. And you absolutely do not use bupivacaine for beer blocks, too much risk of heart toxicity if the tourniquet fails.
Critical point. What else?
Infiltration injecting directly into tissues, and epidural or spinal neuraxialline blocks. For infiltration and epidurals, most local anesthetics work well, except maybe cocaine and benzocaine, which are mainly topical. The choice depends on desired onset, duration, differential block, etc.
Lots of options. Okay, to wrap up the drug specifics, can you give us that quick summary, short, intermediate, long-acting drugs, and how potency relates?
You bet. Broadly speaking, short-acting. Procaine, 2-chloroprocaine. Think maybe 30, 60 minutes for a nerve block. Intermediate acting, lidocaine, mepivacaine, prilocaine. Maybe 60, 120 minutes for a block. Long-acting. Etidocaine, bupivacaine, levobupivacaine, tetracaine, ropivacaine. These can last several hours, 180 minutes plus for nerve blocks.
And in potency.
Generally, potency is inversely related to the concentration needed. The less potent, shorter-acting drugs like procaine need higher concentrations to work compared to the highly potent, long-acting ones like bupivacaine, which are effective at lower concentrations. Lidocaine is intermediate potency. Understanding that helps choose the right drug and dose.
Okay, that's a ton of information we've covered. Let's just quickly recap a few things that really jumped out. That huge range for TNS incidence with lidocaine, 4 to 40%. That's pretty striking.
It really is.
And all the factors affecting PDPH, risk, patient age, sex, pregnancy, needle size, needle type, even needle orientation. It's not just about making a hole.
So many variables involved, yeah.
And the big difference is in how long these drugs last and how potent they are, plus the ability to tweak duration with things like epinephrine.
Ugh.
It really shows how much thought goes into choosing the right anesthetic plan.
Definitely. It's about matching the pharmacology to the patient and the procedure. And hopefully understanding some of these details helps put medical procedures into a clearer context for people, whether they're patients themselves or just curious.
Absolutely. It gives you a real appreciation for the complexity and the skill involved. You know, considering everything we've discussed, the different ways drugs work, how long they last, the potential side effects, the technology like ultrasound, it really makes you wonder about the future. What's next for regional anesthesia? Are we moving towards even more personalized approaches, maybe based on genetics or new drugs, or smarter ways to deliver them to make it even safer and more effective?
That's exactly where the research is heading, trying to refine techniques, develop safer drugs or adjuvants, use imaging even more effectively, perhaps even predict individual responses better. It's an evolving field. And if any specific part of this sparked your interest, there's so much more detail out there in the textbooks and literature. Definitely encourage further reading for those interested.
Great advice. Well, thank you so much for walking us through all of that. It's been incredibly insightful. We hope this deep dive has given all of you listening a clearer picture of the fascinating world of regional anesthesia. Until next time, keep exploring.